Health Plans, Benefits, and Qualifications Advisory Committee meeting for Access Health Connecticut. Martian, why don't you start off by making an announcement?
Yes, Mr. Chair, this meeting is being recorded for minute-taking purposes, as well as for posting of the recording of the proceedings on the agency's website. This meeting is also being live-streamed on the Access Health CT website. It is also requested that participants introduce themselves every time they speak. Thank you, Mr. Chair.
Okay, thank you. Could we have a roll call?
Yes, Mr. Chair. Groundritter, Chair.
Yes. Yes.
Sean King.
Here.
Thank you, Mr. King. Mark Schaefer. Mr. Schaefer, that's a roll call for attendance.
Here.
Thank you. Matthew Brockman.
Here.
Thank you. Manish Zutani. June Goen.
I'm on.
Thank you. John Vercola.
Here.
Thank you. And Trisha Dave, subject matter expert from Connecticut Insurance Department.
I'm here. Thank you.
Thank you, Mr. Chair. That concludes the roll call vote for the membership of the committee.
Could members of the senior leadership team now introduce themselves?
Good morning, all. James Michelle, Access Health Connecticut.
James.
Hello.
Good morning, everyone. Holly Swick, Director of Finance, Access Health Connecticut.
Okay.
And Kelly Cody, Plan Management Manager.
Okay. I think that's it for now. Any public comment?
No, Mr. Chair, we did not receive any public comments today.
Okay. So next, could I have a motion to approve the minutes from the March 25th meeting, just a week ago? One of the board members, maybe, one of the committee members.
Motion. This is two.
Thank you, Two. Seconded?
Second.
Were there any changes or edits anybody like to make? If not, could we have a vote on that, please?
Groundritter,
Yes.
Sean King,
Yes.
Mark Schaefer,
Yes.
Matthew Brockman. Mr. Brockman? I think, Mr. Brockman, you're muted. June Goen,
Yes.
Manish Zutani, and John Vercola.
Yes.
Thank you. Motion passes.
I'm a yes, sorry.
Okay, thank you.
All right,
Thank you, Mr.
thanks.
Brockman. Appreciate it.
Okay, I'll turn this over to Kelly now.
Thank you.
Follow-up.
Yes, so we had a couple items that were of follow-up. The first was I forget who it was, if it was Mr. Brockman had asked for a year-over-year comparison of the metal tier enrollment by federal poverty level. So before you is that comparison. Again, we have a lot of other topics to talk about, so I'll just kind of go through this fairly quickly. If anybody has any questions, let me know. But when you look at it from a year-over-year perspective, again, you're not really seeing anything groundbreaking. We are seeing what we had expected in the 400 to 500 range. You can see the numbers dropping down in 2026. You can see in the 350 to 400 FPL level, that enrollment did go up a little bit. So perhaps people's income changed from the 400 to 500 range down a little bit, which is possible. But nothing is really sticking out as being unusual. So just wanted to put that out there. If there are, sorry.
Well, I think I actually was quite struck by the findings. I think it's hard to compare the two side by side because you use different scaling on the left, stuff up to 35,000 on the left and 40,000. So at first glance, it looks like silver is for 150 to 200 is constant. But if you look at the numbers, it's an increase of 5,000. So If the scaling were the same on the two charts, it would make it easier to understand how things have changed. So I see a significant uptick in the silver for under 150 and from 150 to 200, and more significant declines in the 400 to 500 and 500 plus up. So it does look like that, despite the fact that we had an overall net increase in enrollment over the previous year, that there was a significant expected drop off in the over 400.
Yes, that was definitely a number that was expected. And you were correct. I mean, the numbers have gone up in the 150 to 200 range, but I think that is, a part of all the enrollment that we are seeing. In the Covered Connecticut arena. So again, yes, you're right, the numbers did go up, but it's not anything that is unexpected.
So Mark, we will update the chart, the scales. So you get a better visual
Yeah,
about
that
that.
would be.
Yeah,
Okay.
we'll do that and get it out to the committee. And but to Kelly's point, the Cover Connecticut continues to grow as TMA, as people come off TMA. Most of them are going to Cover Connecticut, so we expect that to continue to grow over the years. That one concern I do want to give the committee a heads up about that we have. I think I sent a note to the board about this. That is that 350 to 400 that went up. Some people may have tweaked their income level below 400, right? Which is fine if it's real. We assume it's real for most folks. But one concern that we have is that there's a cap for up to December 2025. There's a cap on repayment of over APTC amounts that you were entitled to. There's a cap. When you reconcile your APTC with the IRS with your taxes, there's a cap. For 2026, that cap is removed, which means that if your income is much higher than you had projected for when you apply for 2026, you would have to pay the entire amount between what you were entitled to and what you received. Whereas in the current 2025 was the last year that you were entitled, where there was a cap to protecting folks, in terms of what they have to pay back. And that was I believe that was part of the HR1, the HR1 bill that the president signed.
Yeah.
So, and we do have a strategy to communicate that going forward and throughout the year, making sure everybody's aware that you have to come in and update your income to reflect what the changes are, what the new income level is. Just coming in up or down. If it's down, you may get some benefits, some more APTC. If it's higher, you protect yourself from having to pay a big tax bill to the IRS with no limits. And again, we have a whole strategy about communicating that throughout the year to our customers. But that might have been, some people just tweak their income so they fall below 100% to get something. We want to make sure that any risk associated with that they are aware what the exposure that they have. But Mark, we will update the chart so that the scales are identical on both charts.
Yep.
And my apologies for that.
Thanks so much, James.
Yes, sir.
There were two other updates or two other requests for information. One was comparing the standard gold plan to all of the non-standard gold plans. For the sake of this meeting, and because we've already voted on the gold plan, I won't go over it at this point, but in the last three slides of this presentation, there is that comparison, should anybody still be interested in looking at that. And the third request was the comparison for the CAT plans, the catastrophic plans, against the bronze plan that we're introducing this year. So that has been embedded into the presentation that Ren is going to provide to the group. So I hope that captures all the questions or requests for information from the previous meeting. If there aren't any questions, we could move on to Ren's portion of the presentation.
Okay, Ren?
Thanks.
Hi. Hi, good morning, everyone. This is Ren's consulting actuary from Reco. So let's move on to the first slide about goal plan. So I marked as approved final for option 2, just for a refresh of our last meeting. And we can move to the next slide for a silver plan. I think we'll emphasize on the decision on the silver plan today. So last time we got the valuable feedback, like we get an option kind of in between of option 1 and 2, increase the deductible a little bit and modify the copays a little as well. So we came up with an option 4 in light blue. So if you take a minute, look at the modification. So we kind of, the deductible is 5,500 in between option 1 and option 2. And also the copays, instead of increasing to 65 in option 1 and no increase in is option 2, we kind of, we still keep in option 2 copay for primary care, but we do increase slightly from option, like between option 1 and 2. So we settled the specialty copay to 80 and then also urgent care to 120. So that's option 4. If you have any feedback or suggestions to modify option 2, but so far both carriers tested okay for this both AV and mental health parity compliance. So if option 2 is feasible, we can vote on option 4 today. I can pause here a little bit and then get any
What
feedback,
do other
insights.
Right. What do other members feel about the 3 options here? Or actually, there's 4 options now. Certainly, 3 and 4 are kind of the compromise options.
So I'll weigh
Any
in, Grant.
opinions?
I like the balance of the option 4 and think that that hits the right notes.
Okay. Any other? Well, I certainly think 3 and 4 are the 2 that are really.
Mark, were you rooting for 4 there? Sorry, you said.
Yeah, I'm sorry. I do like 4. I like the slightly lower medical deductible, and I think the primary care difference of 43 versus 45 is nominal.
Yeah.
And the urgent care is still a way better deal than going to the emergency room, so that not outrageous, but
yeah. Okay. Should we look at the other silver plans first before we actually do a vote, I think. And was there any issue with, if we did take 4, are the other silver plans okay? They have to be at least 2% higher. Is that right?
Right. Yeah, let's move on to next slide.
Yeah,
Look
next
at the
slide,
silver
right.
73. So I marked the option 2 as approved preliminary because that one has the highest AV possible. So it's, the option 1, it won't meet that 2% difference criteria.
Gotcha.
So
Right.
yeah, we have option 2 as a better option now. So
Excellent.
actually we did the base plan kind of based on this option 2. So we make it 2% lower than option 2 of this 73%.
So we are 2% higher, right?
Yes.
Got it. Great. I think, and this is 2% higher than option 4. If we chose option 4,
Yes.
this would be 2% higher. Excellent.
Yes, correct.
Okay. Wow. Seems to be like a winner then.
Yeah.
And the difference is only like $2 on the primary care, and a few other things, but that's great.
Mhm.
Okay, thank you. Let's go on to the 87.
Yeah, this 87, I think it's the simple one, have very few changes. And I think we were talking about approving this one, and I just recommended, yeah, let's do the silver altogether. So I think this one I marked it preliminarily approved as well.
Okay. Any comments?
And
Looks good. Looks good from my endpoint.
Good.
yeah, okay, then let's move on.
Let's move on
94.
to 94. Yep.
Yeah, this one, yeah, two options. One is we increase the out-of-pocket maximum and to keep the copays the same. And the option two is, yeah, we kind of increase the MOOP slightly, just kind of a little balanced increase copay slightly. And so we need to vote down this one, option one or two.
Okay, so this is your typical choice. Do you raise the out-of-pocket max or do you raise the copays? What does
Yes,
anybody
yeah,
else-
because deductible is 0 already. Yes.
How does anybody else feel about that?
I'd rather raise the out-of-pocket max than the copays on this
Okay,
particular plan.
thank you.
Agreed.
Um,
And I'm okay with that.
This is the lowest income group, and they really do feel the copays, even a slight increase in the
Mhm.
copays.
Yeah.
Only a very few of them actually hit the out-of-pocket max.
Mhm.
I'd go with
okay.
one here.
Yeah, Grant,
All right.
our experience, Grant, $2 more, could be too much. So
Yeah,
I think
exactly.
I think we're in the right. Yeah.
Right. Very sensitive to the copays.
Yeah, okay. So 94%
thank
is
you.
option one. Okay,
Yeah.
let's move on
Okay,
to
I think-
yeah, let's move on to bronze. And there are yeah, quite a few options here. And first we would look at the non-HSA plans. So we have two options. I think we didn't vote on this one last time. Or we wanted to look at all bronze together in order
So,
to have a better decision. I think the difference of these two options is, yeah, for option two, I just want to demonstrate if we want to get specialty care, not subject to deductible. So if we want to do that, and we need to increase the MOOP slightly more, and also, yeah,
yeah, and I was really in
All
favor
right.
of having something in the bronze plan that was not subject to the deductible, because otherwise they really have to pay a fairly large amount of money. That's a $8,000 deductible before they get their first real benefit other than the primary care, or the preventative care, I guess. So I was in favor of option two, even though it does have higher copays, because it's before the you don't need to meet the deductible to get specialty care.
Mm.
That was my feeling. Any other thoughts?
I'm reluctantly inclined to agree.
We're all reluctant about the high deductibles. Yeah,
That's fine. Yeah.
yeah, okay. Thanks.
so option two, yeah. Okay, yeah, we can skip this one. And here I put all the HDHP plans, the current plan and our new proposed the bronze light. And also on the very right, I listed the catastrophic plan, the current 2026, and the potential 2027. So if we start with the current HSA plan, I think it's a simple modification, just increase the out-of-pocket maximum from seven, to 8,500. So that's a simple one. I think we approved that one. And then the new plans have two options. And for catastrophic, I think right now is that maximum allowed amount for 2026, which is 10,600. And I just, since carriers haven't decided, so we don't know for sure what carriers' new catastrophic plan would be for 27. I just assume it still will be the maximum allowed out-of-pocket amount, which is $12,000. So that's just for comparison purpose. I list on the right, and the two new bronze light, we have maximum the MOOP $12,000 and deductible 8,000 and a different co-insurance.
Right.
And I
so
think last time, I'm sorry, the premium differences, we hadn't collected information from both carriers, but just a rough estimate, kind of right now, for a 30-year-old, the catastrophic plan cost around like 300 to I think it's $500 to $600 for for a 30-year-old. No, let me see. Let me look at my note. Oh, it's like $300 some for the catastrophic plan. But if they age out, it will cost like $500 to $700 when they age out currently. So if we have a bronze light plan, the difference might reduce to like half, like only between $150 to $250 difference. But again, if the potential 2027 catastrophic plan, the deductible increase to $12,000, that gap will be widened again. So it might be still, I would guess, like between $300 to $400 difference if the new catastrophic plan get a lot leaner as well in 27.
I think we're going to go with the potential 2027 catastrophic plan. You only have one there, and it's to raise to $12,000. So that's pretty much what we have to do. As far as the bronze lights, there's two choices: 20% co-insurance or 50% co-insurance after the deductible, or after the deductible. Yeah. And it only makes a 1% or maybe 1.3% change in the premium. Now, the premium on the bronze light, is that somewhat comparable to the premium on the catastrophic plan, like $300, $400 for a 30-year-old?
Yeah, I think it will be still a lot more than the catastrophic.
Yeah, a lot more.
Yeah,
Okay.
it's more than $200 more. Yeah.
Okay.
Right. And so the purpose of this, though, was to bridge those people who may not be eligible for a catastrophic plan or choose to go into a bronze plan, and also be APT. Geez, that's a hard acronym to say this morning. The tax credits, let's just say, where they wouldn't necessarily be available under the catastrophic plans. So this is another option that was thrown out to the group to decide if you guys really wanted to add to the standard plan grouping an additional plan to help bridge those individuals. So instead of offering two standard bronze plans, one being HSA compliant or an HDHP plan, technically called a high deductible health plan, and another the light to help offer a better suite of options to those individuals that might be looking for coverage but not looking for a silver or gold plan.
Well, it does appear to
Right.
me that option 1 on the light is better than option 2, just because 50% copay is, or coinsurance is a pretty high.
That's, Grant, that's coinsurance on inpatient care. Is that what that is?
Well, that's a good question.
Yes,
It actually follows all the way down for the diabetic supplies, the other medical. It's consistent all the way down.
Right,
Yeah.
but the line, the coinsurance line, which goes from 20 to 50, it doesn't change from 20 to 50 for primary care and specialty and that sort of thing, but it jumps from 20 to 50. That second line is specific to inpatient care,
Yeah,
right?
it's only, yeah, right. It still stays 20% for the.
And is that not after deductible? In other words, that's
Both.
immediately applicable?
yes, all after deductible.
Even the 20% where it's not labeled after deductible? Even the
Yes,
second line?
after deductible, which second line?
So the
oh,
second
yeah,
line is
Yeah,
Crow
yeah.
and towings.
yeah, over here, yeah, 20 and, yeah.
The Mark, I'm sorry, Mark, what was your question, Mark? The
Well,
20%?
there's the first line is combined medical and pharmacy deductible. The second line is coinsurance. And I assume
Right.
coinsurance is not copay, it's specific to inpatient care. And it's the only line that's not labeled after deductible, which leads me to believe you immediately get the benefit of the 20% on inpatient care. And if that's the case, it makes it a substantially better option to have the 20% than the 50%.
Yeah.
Yeah, I
Although
think, yeah, the default is all after deductible.
in the fourth line, Mark, in that bucket of words is inpatient hospital. And it appears, so I'm not sure what coinsurance versus the inpatient. I guess I'm lost there.
Yeah, so thanks for pointing that out. I didn't see that.
It's
And
all
either
after
way,
deductible.
that's after deductible. It's 20% in both places after deductible.
Yeah, right. So, okay. Well, I still think the 20% is a better deal.
Okay,
Since
so,
it does raise the premium, but probably not by enough to make up for the 50% for so many of the services.
yeah, yes, I agree.
So
option
just for
one.
future reference, Grant, it would be great to asterisk and spell out then what the coinsurance applies to, because it's not clear to me.
Yeah.
Like if it's 50% on basically no services remaining outside of the wordy bucket, then it's not material.
Yeah, I'm not sure what
Okay.
all other medical means, to your point, Mark. What's coinsurance then all other what's left?
It's probably home health and chiropractic services, things like that, maybe. And drugs.
They got chiropractor in the bucket.
So Rand, can you define when we say all other medical?
Oh no, I see.
You are one of the insurers, and
Yeah.
what exactly what does that cover?
Okay.
Yeah,
Yeah.
yeah, you're right. A lot of things are in that second.
Okay.
Okay.
Well, I mean, are we able to clarify that for the committee members? What do we mean by all other medical?
Yeah. Okay. I'll come up with a clarification on that. I think this was might be in the benefit summary sheet.
I think that the all other medical is just to capture any of the items that aren't already listed under that one bucket. So it's probably, I mean, lack of a, off the top of my head, but it's, any other services outside of that. I mean, and there's a whole host of different types of services. So I think these are, the more prominent services that are outlined. These are the services that we as the committee identify as the core services in the plan design that are offered through Access Health that we talk about here. But there are many other ancillary services that are provided, which couldn't possibly be listed on the list, but it wouldn't be, the big services such as inpatient hospital or outpatient services types of scenarios. I don't know if anybody from Anthem or Connecticut wants to interject if they have any thoughts or commentary on that as well.
But what about the co-insurance versus all the things listed? What is the primary subject of the co-insurance?
I think historically, just listing the co-insurance at the top is just to give you an idea of what the benefits, what co-insurance level would be applied to all the other services. So I think it's just, it's pretty, I think it just goes in line with all other medical line. That I think that's all the intent of it.
Okay.
Well, another important issue is the drugs. If you look down at the drug line, that matches the co-insurance line. I think it's telling you about the drugs co-insurance, if nothing else. And the diabetic supplies.
No, because Grant, because one's after deductible and one's not on co-insurance versus all those other lines.
I think historically the co-insurance line that was put there was more for a visual for you just to see what the overall co-insurance level could be for the plan options. It's not aligned with, I think it's just a something to look at, but not, it doesn't apply to every single benefit line that's on there. So that's why, under the primary care, it says 20% co-insurance after deductible. And all other, it says the 50. So I don't think we need, I think for the intents and purposes of looking at this exhibit, the co-insurance line is somewhat irrelevant. The focus should be on the specific lines that identify what the services are and what the member cost share amount is.
So
thanks, Kelly. Yeah, I just want to clarify. Yeah, the co-insurance by default is after deductible. So if it's before deductible, it will be specified like co-insurance before deductible. Otherwise, it's after deductible.
So can I make I feel personally comfortable enough. This new bronze light thing is an experiment anyway. We're trying to see if we can, be a little bit more attractive for some group of people than the catastrophic, and try to hold some people who no longer feel they're required to buy insurance to stick with us if this helps them get some premium subsidy. So I feel confident enough on going with option one. I would ask to Wakely, maybe for all of these, when I believe our next step is that the full board of directors votes, I would ask for more detail on what do your benefit categories mean in these charts, because now I'm wondering if maybe our understandings as a group are a little bit off from maybe what you all have, and I think that would be helpful when we take the actual formal vote as a board.
So, hey, Matt, would you be open to having another quick meeting next week with the whole committee? Just a quick follow-up meeting, so to make sure the committee is comfortable with the definition before we go to the board. I'd feel more comfortable if this committee could support this with all of the information and knowledge that you need before we go to the board. Because the board doesn't meet until for another 3 weeks from today.
Okay.
That's,
James,
I know we're, hello?
Are you suggesting we hold off the vote, or should we vote today, but then have another meeting next week just to?
Either way works. Well, I'll be more comfortable with the committee being more comfortable. Is comfortable with everything that we're telling them, and not voting without full understanding exactly what they're voting on.
Okay, all right. Well, we seem to have very, very good candidates, so we could wait till next week to actually get the final word on them, and then if we're comfortable voting, then certainly.
And I'm
Okay.
not asking you guys for another meeting. My apologies for putting another meeting in your calendar. This is so important. Everyone needs to be very comfortable with what they are understanding and voting on before, because this is for 2027. This is a key. And one of our objectives for 2027 is we're looking at affordability across the board to the extent that we can. So this is our attempt to try to deal with that. But we want to make sure the committee is fully aware of everything that they're voting on before we move to the board.
James,
Yeah,
I'm
and-
comfortable with a quick touch next week to have
Sure.
complete, and sort of thoroughly annotated exhibits and do the
Yep.
vote.
Okay.
And can I just for clarification purposes, Mark, are you asking that you would like to see this slide presented similar to the others where it breaks down each line of coverage?
Or that the lines on which we've had the questions are somehow reconciled, and that there's also clarity of labeling that if the 20% coinsurance is after deductible, even if that's assumed, if it's not labeled before deductible, it's just an irregularity in presentation that makes me less comfortable than if it was.
Yeah. So we will provide more clarity so that the charts will speak for themselves. I think over the years we've gotten more comfortable with this committee. I think that we need to be a little much more clear with especially with the new product. So everybody's very aware of what we're doing, what we're proposing before they vote.
And James, that was just my opinion. So it may be that other committee members would prefer a format that sort of break things out like the others. I'm fine either way.
Okay.
Yeah. And I think just for simplicity purposes, to explain why this slide is the way that it is because there is no cost share difference for all of the services that we've just talked about on all the other plans, with exception to on option 2, where the diabetic supplies and the drug is at 50% after deductible. All services for option 2 are at 20% that are named, but we're not so the coinsurance amount that's 50%, you may not see that benefit listed. So I think I understand the confusion. I think that listing the coinsurance line separately probably added confusion. We'll make sure to eliminate that. And I think the all other medical, because those are two things that we don't talk about when we're looking at all the other prescribed benefits.
So in this case, the all other medical, unless I missed it, does include home health. Is that right? So you're not suggesting, Kelly, removing the all other medical line, or are you?
No, what we can do is we can list the benefits, make sure that there is a one for one match with what was presented on the previous views. Yes.
Makes sense.
Can I also
Put in NA
this is Sean.
for coinsurance on the light plans, because it really doesn't apply to anything.
Grant, can I jump in also one additional thing? Can we also, because I think the last presentation had, at least for a couple of charts, some indication of the variations in premiums between when we're comparing the plans.
Yeah,
Can we get that too when we're comparing all these different bronze type plans and the
Mhm.
catastrophic plan, those having those variations, that visual is helpful too. Thanks.
Right. What's the difference in premium between option 1 and option 2? That would be
Yeah.
good to get a feel for, at least for some age groups. Okay. All right. Well, what I'm hearing is we'll touch base next week to actually vote on these, but we do seem to have a pretty good feel for which ones we want, but we just want a little more clarification as we present them to the board, particularly.
Okay.
And Grant, is this one particular that's
Yeah,
that's
this one is the one. I think the
that we need to
silver
provide
plans
more
actually-
clarity? Right.
Yeah, we actually have a good idea for the silver plans. And for this catastrophic plan, I think we're good with this one too. Do we want to move on to the dental plan? Okay.
Okay, for the fun plan. So this is the standalone dental plan. What I'm presenting to you is the 2026 enrollment by coverage level. And so what I mean by coverage level is we have different levels offered through the issuers. There's a preventive care only. There's a plan with preventive care and basic restorative services. And then there's a full coverage plan, which is includes preventive care, basic and major restorative. Excuse me. So overall, this year we have 19,000 individuals enrolled in the plan, which is great because year over year our enrollment numbers continue to rise. Of the 19,000, 57% of those enrolled in the plan are enrolled in a full coverage plan. So looking over at the side, I broke out the non-standard plans enrollment to the standard plan enrollment. And as you can see, the majority of the enrollment is in a non-standard plan. It's about the enrollment in the standard plan, which is a full coverage plan, makes up about 15% of the total dental enrollment. And if you compare it to just the enrollment of the full coverage plan, it makes up about 27%. So it's about a quarter of the membership that's enrolled in a full coverage plan. I will comment here that our preventive only plans, that enrollment could be higher, but several of the health plans that are offered through Access Health also include preventive care for adults, as well as dental coverage for pediatric services. So some of those plans that have the adult benefit may be detracting people from enrolling in the standalone dental plan because it's embedded in their health plan. To the right of the view are 2026 rates. They are broken down. The first column is pediatric rate, and which is age 25 and below. And then there's adult rates, which is age 26 and above. So that's how they're broken out. They're in the order of coverage level, meaning preventive only, preventive and basic, preventive, basic, and major. Anthem offers two full coverage plans, which is the family plan, and then our standard option. CICI offers just offers the standard plan, but also offers the preventive only care. And then Guardian offers the same types of plans that Anthem does, offering the preventive only, preventive basic, and then full coverage, two plans that are full coverage. So as you can see here, the standard plans, the pricing for our standard plans is a little bit higher than the non-standard plans. But people are still enrolling in those plans, so they obviously like the level of coverage that they get. Any questions on this slide before we move on? Okay, we can go to the next slide. So as we talk about each year, CMS reviews the annual limitation on cost sharing, and that is reconciled by them. So we have the ability to increase these amounts each year. I want to remind the group that this only applies to the pediatric portion of the benefit, does not apply to the adult portion. In 2026, the amounts did increase to $425 for one child and $850 for two or more children. At that time, the HBBQ recommended the amounts stay as they have been since 2016, and they remain at $350 and $700. For plan year 2027, after CMS's review of the data, they have allowed that the amounts could be increased up to $450 for one child and $900 for two or more children. For the sake of conversation, these amounts we do not have to change the amounts. We don't have to go to the maximum amount if we don't want to. And we did reach out to both issuers to ask if we were to make any plan changes for 2027, and decided to increase from the $350, $700 to the max, the $450 to $900. It is on average worth about $1 PMPM on the pediatric rate. So it's pretty insignificant, but wanted to share that with you. Before we go to the next slide, are there any questions?
Is it safe to say that your recommendation is just stay with 350, 700?
Well, if we go to the next slide, we did come up with a couple options just to throw out to the group for consideration. There have been no plan changes since 2016. So we wanted to put something out there to you to look at. It doesn't mean that we need to make any changes. The enrollment is, as shown on the other slide, the enrollment is I wouldn't say significant, but there's a good portion of the individuals that are enrolling in that full coverage plan. Obviously, our enrollees want the full coverage. They don't, the majority of the membership is in those full coverage plans. So what we did was we asked both issuers to provide pricing as it relates to making some minor benefit changes. One of them is increasing the out-of-pocket maximum on the pediatric benefit only to the $450 in both options. And then under both options, changing the diagnostic and preventive services from zero copay, and the deductible doesn't apply, to leaving it zero copay, but after the deductible. Please note that the deductible under both options is $60 and it maxes out at $180. The other change or pricing request was changing the basic services from 20% coinsurance after deductible to 25% coinsurance after deductible in option 1, and then option 2 bumping it up a little bit further to 30%. These changes don't have a significant impact on the overall pricing. From option 1, if all of those options were changed, you're looking at potentially an estimate of, and this is looking at 2026 rates, it's not looking at 2027, but you're not going to see more than a $6 change for the pediatric rate, a reduction of $6, or a reduction of $4 on the adult portion of the rate. For option 2, that change in benefit on the pediatric portion, you might see an estimated $7 change, and then on the adult, it would be maybe around $5. So again, overall, it's really not that significant of a an impact to the rate. So, but I wanted to throw it out to the group because I know that cost has been something that everybody is kind of focused in on. I wanted to throw out some options, but not necessarily looking to make plan changes, but wanted to inform the group if we did make these changes, what the impact to the rate might be.
So again, Kelly, we're just looking at impact to the rate, but we're not, the impact to customer behaviors could be significant in that if they have to come out of their pocket, for example, diagnostic and preventative services, copay after deductible. I know it's $60 or $180 max, but for some folks that's a lot of money.
Yeah, I agree with
Whereas-
James. I was gonna
whereas-
comment, same
yeah.
thing.
Whereas under
Yeah.
the current plan, those services zero copay.
Brings them in.
While the rates don't, the impact to the rates are minimal, but we just want to give you the full picture. All right. Again,
Absolutely.
and we're looking at affordability across the
Yep.
board.
And so,
But more important, the impact to our customers is probably again we want people to go get the services because again for some folks $60 is a lot of money. For
yes.
some folks $60 is not affordable. So I just want to put that out. It's not just about the premiums, but it's also will people use the plan if they have to come out of their pocket.
Absolutely. And just to, hearing your comments, this plan is still far richer than any of the other plans that are continuing to be offered on the exchange as compared to the non-standard plans.
Even option 2 is far richer, but
Yeah.
but still it does require a copay deductible
Mhm.
before.
Absolutely.
Okay. Well, I think James, what you're recommending is just stick with the same design for 27. Is that
I mean, that's
because
the
of the
reality.
psychological?
Yeah, I mean, if it's going to cost people more money to get services, and if we could stick with the same design, and I think we ought to look at that seriously.
Okay.
I'm okay.
Could I ask, is there a family plan or do you pay for each person individually?
People are, they're enrolled. It's by age. So if you have a family of 4 and you have 2 adults at age 56, they get age 56 rates. And if you had 2 children, it would be
2 children rates. Okay. But the children, if they do sign up for the health plan, the children get their coverage included, right?
yes.
Okay, all right. So I guess we're gonna have another meeting. Myson, do we have a date for that or a time?
Yes, Mr. Chair, we do have a date. I believe it's April 9th at it's a Thursday, April 9th at 1 p.m.
Okay. I think we're gonna get a little more detail then and vote on all these plans then. But I mean, we have a pretty clear idea from what we've heard today, which ones we want, but we do want to have a little more detail on them to make sure what we're voting for. And making a recommendation to the board, the full board. Okay, great. Tentative meeting 1 p.m. on April 9th. That's it for today.
We'll change it to permanent, Mr. Chair.
That's right. It's not tentative anymore. All right. Okay. Thank you. So is there any, okay, if there's no other business, could I have a motion to adjourn?
So moved.
Thank you. Seconded?
Second.
Second. Great. Roll call?
Grant Ritter,
Yes.
Sean King,
Yes.
Mark Schaefer,
Yes.
Matthew Brockman,
Yes.
John Gowen,
Yes.
Manisha Jutani, and John Verkla.
Yes.
Thank you.
Thanks, everyone. Talk to you in
Thank
about
you
a
all.
week.
Thank you.
Thanks, everybody. Bye-bye.
Bye
Thank
now.
you.